So this is Donna Piercy. She's a registered psychologist. She has her master's in counseling, and she provides counseling to individuals experience a whole variety of difficulties, which include, and pretty much a large focus is on chronic pain, chronic health challenges like neuropathy, complex traumas, accidental injuries, which is what brought me to all of this, and work-related injuries, PTSD, a whole variety, anxiety, depression, anger, stress management, self-esteem, self-efficacy, a whole list of areas that she has been working in over the long number of years that you've been doing this. Her credentials include certification as a registered psychologist. She's a member of the Psychology Association of Alberta and College of Alberta Psychologists. She has a master's degree in counseling, a postgraduate chronic pain certification from U of A postgraduate diploma in educational psychology with a specialization in rehabilitation. She also has a Bachelor of Physical Education and is a certified exercise physiologist by the Canadian Society for Exercise Physiology. And she's also a member of the Exercise is Medicine. So when she's not busy doing all of that, her interests include swimming, some weight training, equestrian events, hiking, and traveling. She lives in a rural location, and she really enjoys looking after all her animals and her 7 horses. So please welcome Donna Piercy.
I hope everybody can hear me, and if you guys can't hear me, just put your hand up. And I'm going to do a presentation on chronic pain, and everybody here has pain of one sort or other, lots of neuropathic pain, I understand. And as I go through this, feel free to be interactive and ask me questions. And just a little bit of additional background, I have rheumatoid arthritis. I'm also diabetic, and I'm at the point with my RA that I take, the heavy hitters. I'm on the big drugs, the injectables, Humira. So I've had to really understand my own practice, understand how to manage my pain and my disabilities, and also, work and try to be functional. So managing medication, managing exercise. And one of the experiences I've had is that with having chronic pain myself is trying to educate other professionals, whether it be exercise physiologists or physiotherapists or doctors, about the role of the overall health, not just taking medications, but self-care. And I really do a lot of education in trying to get these people to understand that even though we're supposed to exercise with our pain, if we've got really bad diabetic neuropathy in our feet, it's pretty hard sometimes to exercise. So in this, I see some yeses. I do have neuropathy in my feet from my rheumatoid arthritis, so I totally get this. So ask along, but this is one of the presentations I'm going to use today is I'm going to use one that I did for exercise physiologists to try to teach all these exercise people that it's not so easy sometimes just to do the program that they may want you. So that's one of my missions, is to educate people about chronic pain. So just you guys feel free, throw your hands up, and we'll just make this interactive. And any questions, don't hesitate. Now, one of the issues with pain, and we're just going to review for a minute, and again here, I'm saying, pain serves an important purpose. It's the body's warning signal. But again, with ongoing pain is, the pain sensors in our body don't stop firing. I always describe them to my patients as like we've got spark plugs, and like say if we're working on our feet, is these spark plugs don't know how to stop firing. So the thing is normally when we have pain, right, it's a signal something's wrong. But when we have chronic pain, these spark plugs on the neurons, our pain sensors, don't stop no matter what we do sometimes. So it kind of goes away. And again, the one thing is pain affects everything, and it can be the result of disease or injury. But this is what I'm getting at, is a signaling system. So if you think of our pain as electrical, if we look at it as pain, everything is electrical, that our electrical system in our body does not work. So ongoing pain says something is wrong, which you guys already know. But it's not just physiological. So again, if we get depressed or we're angry, and I'm sure everybody knows that, our pain goes up. So the thing is how do we manage when we get like that? And understanding, when I'm trying to teach people about pain is complex, you know, and I'm sure everybody's gone to a doctor or two, and the doctor has just said, take this medication and you'll be okay. And anybody been there? Yes? Okay. And, you know, when you go back to the doctor, this isn't working, and then you begin to feel like, well, am I crazy? Do you know what I'm saying? And nobody's believing me. So, no, and I know, and this is so hard. So that's the thing is, when we know that 1 in 5 people in Canada suffer from chronic pain, that's a lot of people. And we're just, you know, the Canadian Chronic Pain Society and the International Society for Pain, they're really getting into doing a lot of statistics. And when you think of 1 in 5, that's huge. Huge amount of people. So, and this is why I'm trying to teach exercise professionals. But the thing is that, so we know 1 in 5, so if you're in a room, you know, 18 to 20% of Canadians have pain. 60% of people have lost their jobs. You know, and, you know, 70% were under the care. Now, here's the kicker as a psychologist. 28% had depression, 20% with anxiety, you know, and 11% had both. Now, women are more diagnosed with chronic pain. And does anybody have any idea why women are diagnosed more often?
Go to the doctor more often.
Yeah, and you know what? Men, all you guys in the room, it probably took you a long time to go to the doctor and the doctor to actually diagnose you with chronic pain. But again, so these statistics, if men were really on top of and sort of expressed the way women did, the statistics would be different. But notwithstanding, it's saying that we've got a really big problem. And one of the issues here in Canada, when they've done the research, is that when chronic pain patients are waiting for care, their condition often gets worse. So, you know, and the thing is that that's what's really scary for me as a chronic pain specialist, is that by the time I see people, and I treat a lot of people who've been in, for example, in a motor vehicle accident, or, you know, their doctor sends me, and by the time they get to me, I do a lot of work for workmen's compensation. And by the time people get to me, is their depression is through the roof, and they're anxious, they're not sleeping, and they've been diagnosed a lot of times as malingerers or as just being overactive. And so by the time they get to me, they don't feel very good about themselves. And I don't know, I can see by the nods, some people have been this route. And it's really, really hard to kind of figure this out. So our medical system, you know, is not the greatest here. Now, you guys have neuropathic pain for the most part, but also, I hope everybody understands that when we diagnose pain, our medical profession is really used to acute pain. So acute pain meaning if you break your arm, you get a cast, and the doctor and the physios and all the people involved in your healthcare team, they predict, well, you should be better in so long. Now the sticker, neuropathic pain or chronic pain, is it sticks around. So the medical system is really not educated to deal with this. For example, a doctor going to medical school, and I was just up at the Cancer Centre talking to an intern, they get a one-day seminar in medical school about chronic pain, basically 8 hours of training. A veterinarian gets 88 hours when they go through veterinary school. So our medical system, so what's happening is we're churning out doctors who have no understanding of the intricacies of chronic pain, which, I mean, to me is appalling. They're trying to change that. I just took another post-grad certification course at University of Alberta, and half of the people in this course were physicians, and they ran pain centers, and it was just, unbelievable about the lack of knowledge out there. So I want everybody to take heart that it's really tough when we're going to doctors, because in the doctor's defense, they haven't had a great deal of training of chronic pain. You know, they get the acute pain, but they don't understand the neuropathic pain and chronic pain. So it's really hard for people to access good care without getting really depressed or anxious or thinking you're going crazy. So I'm seeing nods. So this is why it's really hard. So understanding the medical system is playing catch up, and physicians are slowly getting more training, as are physiotherapists and that. But again, a lot of times, even psychology, if anybody's gone to a psychologist, you may have people saying to you, well, the pain is all in your head. Well, that's where it's processed, but pain is real. Go ahead.
I have 3 questions. One was the 88 hours versus the 8 hours of classical physicians.
Yes.
And I'm wondering, why is there that? Why are they keeping 88 hours in
Veterinary school?
veterinary school? Is it to do with that because there's a lot of focus on the nervous system of the dog and like more the biological, like looking at actually what the nerves look like and stuff like that?
Absolutely correct. And because animals can't talk, the vets, they spend a lot more time understanding, the nerve systems and that, whereas in med school, they focus on other things. So unfortunately, and I know it's appalling when people hear that, I have large horses, right, and my vet knows more about pain management for my horses than, the medical system. But again, that the medical schools are seeing that as a problem now with the stats of like 1 in 5 Canadians, and hopefully they're slowly going to get up to speed. But that doesn't help current doctors. Now, current doctors are being asked to go out there and take more training. But again, busy, when you think of a general physician, they have to be a generalist in everything. So going and taking chronic pain courses is not often on their agenda. So please understand, when you're going for care, your doctor, the pharmaceutical rep comes in and says, well, take these pills for pain, and, the doctor's doing the best he can, but this makes it difficult for everybody out there with chronic pain, like, what do I do? So yeah, good. Did you have more?
The second.
I just want to add to that because it fits perfect. Last month, 4 of us, there was Tom, Evelyn, Linda, and myself, went with Dr. Gary Klein to give a talk to second-year medical students on neuropathy. They haven't had it for the last 3 years after Dr. Toth left. They got 15 minutes from Dr. Klein on neuropathy, and then they got 45 minutes from the 4 of us combined about personal experience. So they get 1 hour on neuropathy to go along with that 1 day of pain.
So it fits.
But at least they came to us and they started it up again, even if it's just an hour. But it's, in all their years, that's what they get.
The other question was that if you have pain and it, I don't know, 5 minutes of pain that happens 5 times a day, 5 times a month, and I'm just kind of randomly picking these frequencies, would that fit under chronic pain?
Yes, okay, so chronic pain definition, I'm going to go into that.
Sorry.
So that's okay, because that's a good question, because the thing is pain that doesn't heal within a normal time frame. So again, generally, like I do a lot of litigation work, so when I'm writing medical legal reports for lawyers, I use a generic classification of pain, no matter what it is. If it lasts more than 6 months, it's classified as chronic. Now, again, after 3 months, there's some big debate, like worldwide, between the international guys and the local guys. But to me, past 3 months of pain that doesn't go away and that's ongoing, technically chronic pain. So even if it's intermittent, it still isn't gone. So pain that you shouldn't normally have that doesn't go away. Does that help? Does that?
Yeah, I guess that would fit.
Yeah. Okay. So let's go.
Oh, and the other thing I was going to say was more comment that you said that, it's all in your head, but the medical has this kind of weird classification which is horrible. They say that classification, some of the categories are really valid and stuff like that, but there's something called like somaticization or...
Okay, yes. And I'm going to go to that.
Okay, sorry.
So hold that. No, seriously, this is excellent. Hold the question. Now what I'm saying here again, one thing you guys have to understand is chronic pain is now classed as a disease. So a lot of past medical, it was never recognized. But it's now a disease in its own right. And why that's important is that for anybody suffering from chronic pain, you know, the medical establishment always goes on, you know, fix, cure, you know, broken leg to walking again, you're cured. But there was a really big mismatch, because what do we do with people with chronic pain? So again, now it's been designated as a disease. So medical associations worldwide have to start recognizing this is important for funding, you know, for insurance companies, and so that we can get money to pay for the medications needed, the support needed. So this is where we're going now worldwide, to say this is a legitimate disease. It's not going to be fixed. That's huge. Go ahead.
So is it recognised in Alberta and Canada? I mean, worldwide's one thing, because you have specialised doctors, and, you know, if you're going, like what you're saying, like we're just maybe hearing this the first time, and, you know, you do want to go through insurance, you can get other, you know, equipment or things that you need, you know, at less cost. How do we know that they're, you know, do you say, well, if he's not agreeing with you, could you give me a referral? Is that what you have to do then?
Well, yeah, you have to fight, unfortunately.
See, it's not.
But that's where we're at. We're, to be honest, you guys, in the war against chronic pain, if I can say war, if that's okay with you guys, is that we do have to fight. We have to fight with insurance companies. If a doctor, you know, and I've been through, before I was, just a quick off story, when I was diagnosed, I had rheumatoid arthritis in my hands for years. And I can remember 20 years ago, I went to a rheumatoid specialist. He laughed at me. He said, and he literally said, "Suck it up," pardon my language. And I laughed, never got attention, so now my hands are pretty crippled up. So by the time I actually got to a rheumatologist, but even me, do you know what I'm saying? And I'm pretty assertive, so it's going to be fighting with insurance companies, fighting for that designation that you have chronic pain, and appealing, especially with the insurance companies, and it's really tough.
But even recognise word of mouth, like here, and then we go and tell the people, you know, like, and then your card would be really good.
Okay, well, yeah, and I've got cards, but so this is where we're at, though. And again, chronic pain is a disease, whereas, again, the medical model, you know, broken arm, fix. Chronic pain doesn't often, I mean, we can bring down symptoms, we can bring down, you know, the pain a bit, but once we're diagnosed, it doesn't mean we're going to have severe pain forever, but pain is going to be in the picture. The important thing to understand, in our body, there's permanent changes in our nervous system with pain. And they're discovering that, like in the neurons that are inside our nerve cells, what they've done now with research is they can see there's permanent changes. So it's not going back. Do you see what I'm saying? Where the medical people, like I said, broken bone, fix. Well, chronic pain, when there's nerve damage, especially neuropathic pain or CRIPS, you know, RSD or CRIPS, how I always call it CRIPS, so that's my for RSD. And I have a lot of patients that are CRIPS. And again, there's permanent changes. So we have to understand that there is a lot of, it's complex. Now, one of the problems here is what I'm saying about exercise, I'll just touch on and then I'll go back to, is that when we have chronic pain, it's called kinesiophobia. That's the official word. What it means is we're scared to exercise, because when we exercise, sometimes our symptoms get worse. You know, and so we go to the doctor, you know, and the doctor sits there, and I always like the pictures of the big fat doctor smoking a cigarette from the old days, but you know, don't do as I do, do as I say, right? And the problem, though, with chronic pain is that it sometimes hurts too much to exercise, and yet we know exercise releases the natural painkillers in our body, and I want to talk about that a little bit later, because there's some pretty cool ways to exercise, but we don't have to be jogging, we don't have to go to the gym.
What kind do you recommend?
Well, that's what I'm going to get down, just further down, and that's where I'm going to get you, because you guys, to be honest with you, is for good mental health and pain management, some type of exercise is really critical, but we have to be really creative and find something that we can do without us. Yeah, I will get to that. So anyway, but what happens is we get afraid. So then we go to the doctor, he says exercise, and then we don't. So now it says individuals with chronic pain catastrophize. I hate that word, but that's a word everywhere in medical literature now. So what that means is I have chronic pain, I'm having a flare with my arthritis, I go into my specialist, And, oh, have you been exercising? No, I'm in too big of a flare. I'm really depressed. I'm really upset. And all I can think of is my pain because I can't get it down. So and often the medical professionals say, well, you're catastrophizing. Well, no, we're just totally consumed with the pain. Because I'm sure every one of you guys have had days like that where all you can see is nothing but pain. But again, so how do we, it becomes your whole world. So, hold on here, we're just going to go. So, now, here's the thing, is that medication, and I'm sure everybody's got some experience taking Lyrica or gabapentin or, yeah, all these drugs that are out there and who knows what, right? Opioids. Okay, now, one of the things I see, a lot of people, they come into me and they'll say, well, my doctor gave me gabapentin and I'm not fixed. And I'm going, okay. Now, with a pain medication, the goal, when the pharmaceuticals are designed, it's considered successful if your pain is down 30%. And we don't understand that as pain people. We think that, oh my God, we're going to go in there and I'm going to take my Oxycontin or whatever and it's going to knock my pain down. Well, no. So again, 30% is due to pharmaceuticals. And that just knocks the socks off my patients. They go, you got to be kidding me. And I said, no. So if your meds do that, good. But 70% of pain management involves what we do. So what we do, 70% it's in our ball court, which people don't understand that. And then everybody's looking at me going, well, what? And I'm going, that's what I'm here now. The brain, with pain, even in our brain matter changes, which is kind of scary, but that happens. So exercise can just decrease pain and inflammation, and it helps us to blow off steam. So our anxiety or depression, this is why I'm kind of going in our lifestyle, bottom line here, is how we live with our pain and how we manage it in our medical system is tough, but 70% of that, what we do ourselves, is going to impact how we control our disease. Does that make sense to everybody? And I know I wish I could say the pharmaceutical companies have a magic pill that's going to take off 70% of the pain. But this is the reality we're dealing with. So this is why we have to sort of control our own, which is not easy. So, okay. So, now here's the thing of exercise. There's been a lot of research, and I'm not going to go through all of it. But the bottom line, there's the Living Well, or they've changed the Living Well program now. They've called it a new name.
Row your own boat.
Row your own boat. Yeah, any of those. I used to teach those, but
Better choice is better health.
better choices, better health. So one of the issues is there's a lot of research with what exercise does, and I'm not talking going to the gym and pumping iron here, you guys. I'm talking about sitting in the chair, doing chair exercises, wheelchair exercises, getting into the pool, low, key, moderate. And what they're finding is, number one, with exercise, it can really help with depression, it can really help with anxiety, it can help in a lot of areas and managing pain. In all honesty, I'm a swimmer, and when I start flaring, I will be in the pool. I swim 3 days a week, and I swear I would be in a wheelchair if I didn't swim. So go ahead.
I find the exercise routine, it gets you up and out.
Yes, it does, and there's so many benefits, and it's really hard when your pain is high. But to be honest with you, the big key here is, my rule is when my pain is high, I get into a pool because it's non-weight bearing, easy on the joints. So even if on bad days, I'll go and I'll get into the deep water, put on one of those aqua-sized belts and float around and just swivel myself around. Because just to get away and do some kind of movement, because our bodies need that. Because the problem is, when we're in pain, what happens, we tend not to move. We tend to tense up, and as soon as we tense up, what happens is we inhibit our circulation. We tense, everything gets like this, there's less blood flow. So actually pain goes up. So whether we do some stretches, whether we get in the pool, we need to really actively work on trying to relax, and that's really hard. But again, exercise will help with that. And again, I do understand how hard this is, but when we look at the research that says 70% of how we manage is, you know, the doctors can help us 30% with medication. So this is why it's so important, and we don't understand that a lot of times. But so again, and exercise, when we exercise, even if you go for a walk, go to the pool, our body releases natural painkillers.